Hi, everybody. My name is Bavia, and I usually do the tech for this educational presentation. But today I will be helping to host this conference with the support of MS Focus, the Multiple Sclerosis Foundation. I'm the health educator and the co-editor for MS Focus, and I'm joined today by Dr. Ben Thrower, who's going to answer so many questions in the next hour. And I will just give a quick little intro into him. And if you would like more details, please feel free to visit our registration page and just click his photo, and you can get all of his lovely accolades on it. Dr. Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta. And we're proud to say that he's also the senior medical advisor for the Multiple Sclerosis Foundation. Thank you, Dr. Thrower, for generously giving us an hour of your time. And before we get started, I just want to give a couple instructions for those of you who might be new to this webinar. If you have a question or a comment, please use the Q&A button on your Zoom screen, and it will allow you to send your question anonymously if you would like to do so. Please try not to put questions into the chat area so we can reserve that for incoming Facebook questions and any community chat that may be happening with the attendees. If you'd like to ask your question live, all you have to do is use the raise hand button in the app or press *9 if you're using your phone. So with that said, are you ready?
Absolutely.
Okay.
So, welcome everyone. I am joining you live from the cab of my Jeep from the mall parking lot. I scheduled a little two events too close
On
together,
Facebook.
so um, I am happy to be here. And this is, as I've said in the past events, one of my things
Absolutely.
really love hearing from folks in terms of what's on your mind. So we're going to try to get through as many questions as we can. And so why don't we go ahead and open it up?
All right. So the first question is from Keith. Can you please comment on sulfuridin for MS? It has been in the news lately.
So sulfuridin, I'm not sure what phase we are at trial wise. So I don't think we're quite ready for prime time with sulfuridin. And I'm going to confess on this, I don't know whether this has been looked at more in relapsing or progressive forms. I believe more in progressive forms of MS. So I would give this one a stay tuned. Um, there is just so much breaking right now in the MS world. When we look at new things coming out like sulfuridin, try to sort of kind of grade it for yourself as a healthcare consumer. Are we early in like animal phases? Or are we in early human phases? Or is this something that is kind of ready for prime time and about to get FDA approval? Um, but so much going on right now.
Thank you. Anonymous attendee asks, what are your thoughts on Mavenclad? I can no longer afford Kesimpta and I'm switching to Mavenclad in July if my insurance approves it. I decided on Mavenclad over Burumvi so my immune system won't be continuously suppressed.
So I think Mavenclad has been a great addition to our toolbox. So the generic is cladribine. The way that Mavenclad works is it's almost like it's resetting your immune system. So it's going to knock down populations of both B and T cells. Those are going to repopulate about 6 months after your oral course. And then it looks like they sort of come back in a reprogrammed or less angry state. So typically you're going to do two oral courses a year apart. So you do a course now, wait a year, do another course, and then in theory you're done. In Europe, they do sometimes redose people maybe years later, and so in Europe it's not uncommon to see people maybe get a third course many years down the line. But there is data, many years out after those two oral courses showing good effectiveness. So I would put Mavenclad into the class of what we would consider to be highly effective therapies. I will say when the drug first got FDA approval, we were a little nervous for ourselves at the Shepherd MS Center that because of maybe that suppression of both B and T cells, that we were going to see a very high incidence of infections. And we have been very pleasantly surprised that we have not seen that. The drug has been very well tolerated. A lot in the MS world, we did sort of an unintended experiment in MS therapies in terms of how immunosuppressant they are when we all lived through the COVID pandemic. We saw how different people on different MS therapies did through the COVID pandemic. And typically with Mavenclad, we did not see a higher incidence of hospitalizations or death in individuals on Mavenclad who contracted COVID.
Okay, that's good to know.
Yep.
Debbie asks, what is the latest information about vitamin D2 and MS?
So we know that the majority of people with multiple sclerosis are vitamin D deficient. We think that vitamin D deficiency is one of the environmental factors that can increase the risk of a person getting MS. While the research is not absolutely conclusive, there is a lot of research suggesting that correcting vitamin D deficiency is associated with a decrease in new MRI lesions and a decrease in relapses in people with MS. There was a recent study looking at people who were newly diagnosed with MS who started vitamin D, and it showed that there was a protective effect in terms of delaying their next relapse or attack. So there are two forms of vitamin D that we can take. We can take D2 or D3. D2 is called ergocalciferol. D3 is cholecalciferol. Typically, we prefer the D3. So if you take D2, that is the plant version of vitamin D, your body has to convert that into D3. To me, it makes more sense just to go directly to D3 and you avoid that conversion factor. We can't say that there is a perfect dose of vitamin D as a supplement. The perfect dose of vitamin D is whatever it takes to get your blood levels up into a desired range. We like to see people's vitamin 25 hydroxyvitamin D levels above 50. We also don't want to overshoot. If we run too high with vitamin D levels, there is some risk of ectopic calcification, putting calcium in parts of your body where you don't want it, like your kidneys, so you can have kidney stones. There's some research to suggest that if we add vitamin K2 to vitamin D, that it may help protect against that ectopic calcification.
Wow. Okay. Anonymous attendee asked, it's a three-part question, so I'll go one by one. Can you have both overactive bladder and bladder retention?
Typically not. So normally people with MS fall into one of two camps: small overactive bladder or large underactive bladder. Now, the person can have urinary retention and still have bladder spasms. So that's where it gets a little confusing. So you can retain urine and still suddenly get, urgency and have incontinence, but your bladder is still not emptying completely. How we manage those two different problems, small overactive bladder, large underactive, are very different. We usually want to know which problem someone's dealing with, because if we put the person with a large underactive bladder on one of our typical bladder medicines like a Oxybutin or Detrol or Myrbetriq, we actually may make their problem worse and send them to the emergency room because now they can't empty their bladder at all.
So you answered the other part. The question was, should Oxybutin take care of both? And if not, what should I be on?
Yeah, so if you have a large underactive bladder, some of those people sometimes end up on one of those bladder medicines? They can, but it's a unique situation. If the person is doing self-catheterization or has a suprapubic catheter, so they're doing something to empty the bladder, then that person could be on a drug like Oxybutin to stop the spasms. But you don't want to put the person with a large underactive bladder on one of those medicines unless you're doing something to help them also empty their bladder. I hope that makes sense. Yeah, they can overlap a little bit.
To me, it made sense, but if the person has another question, please feel free to submit it. Laura asks, what do you think about stem cell therapy?
So, and this is one we get, pretty frequently, and I always tell folks we need to back up a moment and clarify what type of stem cells are we talking about? Are we talking about hematopoietic stem cell transplantation or a bone marrow transplant? In which case you're sort of resetting the immune system. You're taking the person's own immature cells from their bone marrow, usually through a blood draw, saving them, freezing them, using chemotherapy to wipe out the existing immune system, give yourself those cells back, reboot a fresh immune system. That is a very effective way for treating relapsing forms of MS, maybe less so for progressive forms of MS. Not FDA approved in the US yet, but I do think there's a day coming pretty soon when that will be an FDA approved, very effective treatment for relapsing forms of MS. Mesenchymal stem cells are the other type of stem cells that people are interested in. And this is more the reparative, regenerative type of stem cells. And so there is a ton of research going on with these looking at repairing damage and reversing disability. There is a little bit of buyer beware with mesenchymal stem cells. While there is a lot of legitimate research going on around the world, there are also for-profit clinics that people can go to right now and spend typically large sums of money to get mesenchymal stem cells. Maybe. We really don't know where those for-profit stem cells are coming from. I would just say be a very smart healthcare consumer if you're thinking about going to one of the for-profit clinics for those types of mesenchymal stem cells.
Thank you. Anonymous question, is magnesium good for MS?
So magnesium seems to be good for a lot of things. So we use magnesium as a migraine headache preventative. We use magnesium to help with leg cramps. Some people take it at bedtime. So it does seem to have some sleep promoting properties. So there are a lot of different reasons we might use magnesium in MS. One of the side effects that we have to watch for with magnesium is it sometimes can loosen stools. In some people with MS, that's a good thing. A lot of people with MS tend to run towards the constipated side, so a little bit of loosened stools might be okay. There are a lot of different forms of magnesium out there. There's magnesium citrate, magnesium oxide, magnesium gluconate. Some people think that the gluconate form is the most available to the central nervous system. So maybe if we're trying to treat migraines, that's the form we want to use. Citrate might have the most GI, side effects. That could be good or bad depending on what your normal bowel function is like. So there are a lot of reasons why we sometimes look at magnesium supplementation.
Just to add a question of my own, I was doing research on it, depending on the time you take the magnesium, morning versus afternoon or night, the side effects can be different, correct?
Correct. And so I would say if you're trying to get through the night for maybe leg spasms, or obviously then we typically use a bedtime dose. If I'm using it for migraines, I tend to go with more morning dosing. I think there's a lot of individual variability also, so sometimes playing around with it, timing and dosing. Most people, I'm starting with a 400 milligram dose, and some people that's a little too much and they have to back off to maybe a 250. I have individuals who tolerate up to 800 milligrams of magnesium per day.
Thank you. Judy asks, what is the efficacy of Aagio's half dose 7.5 milligram in those 60 and older?
So the typical dose of Aagio is 14 milligrams. So some people do use 7. It was not studied at that dose, but in some people we do use that because maybe they have too many side effects at the 14 milligram dose. Maybe they're having too many GI side effects like diarrhea or abdominal cramping or nausea, so we might back off. If someone's laboratory values, say their liver function studies or their white blood cell count was a little on the low side at 14 milligrams, we might back off to 7 milligrams. So I'm unaware of a controlled trial that has looked at 7 milligrams in any age, let alone over 60. But I would say it's not uncommon that we do that, just based upon individual need. Aagio, when generics announced, we have the teriflunomide, the generic formulation, definitely has a niche. As we get older, many people with MS may not need a highly efficacious therapy. Obviously, it's the point of a lot of research, and there's not complete agreement. But I think for a lot of older individuals, teriflunomide or Aagio is a nice thing to fill that niche.
Thank you. Edna asks, when should I inform my employer that I have MS?
Well, that's a tough question. I think there's so many variables into that. And it's going to depend upon what kind of relationship you have with your employer. Does your MS actually affect your workability at all? We see people that, in theory, you should be able to tell your employer you have MS and there's going to be no negative repercussion in a perfect world. Unfortunately, we don't live in a perfect world. And so I think that's a matter of really sitting down with your healthcare team, sitting down if you have a case manager or a vocational rehab person, at your MS facility or center where you're working at, it may be worth bouncing it off of them, because there are a lot of variables in there that there can be both positive and negative implications, unfortunately, of telling your employer.
Thank you. We have a question from Facebook. Karen asked, the BTK that is waiting for FDA approval is good for what?
So tolobrutinib is the BTK inhibitor that should get FDA approval in September of this year. It was tested for secondary progressive MS without activity. So these are people with secondary progressive MS who are not having relapses and or new lesions on MRI. So the tolobrutinib was shown to slow progression of disability in that form of MS. It was less impressive in relapsing forms of MS. So for right now, it looks like the FDA approval is going to be for that specific type of MS.
Thank you. Elizabeth asked, any topical treatments for disesthesia or neuropathic pain like CBD, medical marijuana, red light therapy, or essential oils, or anything else?
So I do think topical CBD may help with dysesthesias or neuropathic pain. So if I was going to use a topical CBD, I would probably find the highest potency CBD that you can get. There are some compounded topicals. So if you go to a compounding pharmacist, this would be a prescription option. There are compounded versions where they put maybe gabapentin, lidocaine, any number. They're probably 10 different kind of concoctions out there of prescription combination topicals out there. An odd one topical are preparations that contain capsaicin. Capsaicin is the chemical that makes hot peppers hot. If you put capsaicin on your skin, it may deplete nerve endings of the chemicals that they use to send pain information back up to your brain. So there's some over-the-counter versions of capsaicin. There's Zostrix ointment. There's one called capsaicin, and there is a new prescription version of very high potency capsaicin topical that is typically used in pain clinics, where they apply sort of a poultice, if you will, of capsaicin that stays on for a short period of time and can be effective for pain management. If you do ever use a capsaicin product, read the instructions, and I would advise using gloves before you put it on. If you have it on your skin and you touch your eyes, your nose, your mouth, or other sensitive body parts, you will only do it once. And you'll have a memorable experience.
Noted. Thank
Yeah.
you. Anonymous question. When diagnosing MS, do you recognize EBV or MTHFR gene as a contributing factor?
So yes. So there are a lot, when we look at the genetics of MS, there are over 200 genes that play a role. And so some of these genes have to do with vitamin D metabolism, some of them have to do with T cell regulation, some of them have to do with how our body interacts with viruses. So yes, I think the harder question is we don't know quite what to do with that yet. Because we know you could carry all of these genes and still not get MS. So that's partly why there's not a genetic test for MS yet. So how do we know that you could carry all the genes and not get MS? We know this from twin studies. So if two identical twins, if you look at twin A having multiple sclerosis, what's the likelihood that twin B gets multiple sclerosis with 33%. So 2/3 of the time, twin B, the exact genetic copy, does not get MS because they didn't have the right environmental exposures. So yes, I think there are so many genes that have been identified that play a role. Again, and I think it's important that we do that research, because as we discover those genes, we discover what do they do in the human body, and does that lead then to a treatment based upon what that gene sort of produces or inhibits or promotes in the immune system.
Thank you. Next question. How do you feel about cholesterol meds that affect the brain function or cause neuro issues like dementia by damaging myelin?
So the most common cholesterol lowering drugs have been the statin drugs, and it's kind of been a love-hate research relationship with the statins. There was a time when we hoped that the statins might actually serve as disease-modifying therapies in MS, partly because of what they do at the blood-brain barrier. There's some evidence that the statins may work on matrix metalloproteinase, one of the enzymes that help open the door of the blood-brain barrier to inflammatory cells. But so far, the studies have been disappointing. They've really not shown the statins have not been shown to be of long-term benefit in MS. And then there's the question, so if they're not a good thing, could they actually be a bad thing? I don't think that the science is completely settled on that. And so I think where we're at right now is that, if between you and your primary care provider or your cardiologist, if they think that there is a strong reason to be on a statin drug for non-MS reasons, that it may be something that you have to look at. There is just maybe off topic a little bit. There is a suspicion that maybe statins are one of the most overused classes of drugs in the United States. That there are a lot of individuals who are on statins that maybe don't need to be on statins. If just because you have high cholesterol isn't an automatic sort of indication that you need to be on a statin drug. There are young people who have high cholesterol, but if you look at their other lifestyle factors, their family history, the fact that they've never had a cardiac or cerebrovascular event, it's not clear that we're really doing something good by putting them on a statin drug.
Right. I have a lot of thoughts about that as well.
Yeah.
But for the sake of time, anonymous question. What are your thoughts on switching from Kesimpta to tolebrutinib for secondary MS when the drug becomes available?
So again, we want to make sure that we're kind of dividing secondary progressive MS up into that with activity and without activity camp. So again, the tolebrutinib is going to be approved for secondary progressive MS without activity, no relapses or new lesions in MRI or both. So where tolebrutinib appears to be effective against the smoldering or low-level inflammation, Kesimpta is a really good anti-inflammatory drug against big inflammation. So I think one of the challenges, if you're on a highly effective drug like Kesimpta, but maybe you're still seeing some slow progression, what if we switch you to tolebrutinib and now we've got something for the low-level inflammation, but now we have a drug that's not going to cover the big inflammation? What we really need to know is, how about putting tolebrutinib together with something like Kesimpta? Then you're covering, in theory, both forms of inflammation. Those studies are not completed yet, so we'll have to see if that's something we can do in the future. To me, the easy person to put on tolebrutinib is the person who's on no disease-modified therapy and has secondary progressive MS without activity. To me, that's the ideal candidate. I think this situation, switching from Kesimpta to tolebrutinib, I think that's going to be a shared medical decision discussion, because I think there is some risk in doing that. That maybe we're covering one type of inflammation for covering the other, and I think there may be some trial and error in that.
We have a question from Facebook to follow up on the statins question that you just answered. Will taking the cholesterol meds make the individual's MS worse?
So I don't think so. So there was one arm of a study a couple of years ago, very high doses of statins. It's like 80 milligrams of a statin drug, which most people are going to be on 10 to 20 milligrams, where there was an arm that at the higher dose that walking got worse. Most people on statin drug are not going to be at 80 milligrams. And so I think for the average person, if your healthcare team feels like you need to be on a statin drug from a cardiovascular or cerebrovascular standpoint, I don't worry about your MS getting worse at the standard doses.
Thank you. Anonymous question. I'm 72. I've taken Avenex for 25 years. I'm thinking about stopping DTM. What should I expect?
We hope you expect nothing. So the ideal would be that your MS doesn't change one bit. And so this is an area of a lot of discussion right now in the MS world, the idea of de-escalating or taking people off of therapy. And it gets a little contentious. There are different camps in the MS world, one camp arguing that this is absolutely okay in someone like yourself if your MS has been stable for a while, and other camps that are expressing some caution about it. The good news is we do have some new tools we can use to monitor someone like yourself if you go off of Avenex, in addition to just listening to how you feel, doing things like a timed 25-foot walk or neurological exams. There are biomarker assays out there now. There's a group called Octave that has a blood test that looks at 18 different biomarkers, looking at inflammation, neurodegeneration, that you could argue that maybe if someone's going to go off of treatment, maybe you do that blood test before they go off of treatment and then repeat it at some time interval after they've gone off treatment, and use that as part of your decision as to whether they're truly stable. Some of the new MRI programs that are out there are quantitative volumetric programs that look for things like slowly enlarging lesions on MRI. So we think if someone like this individual was going to get worse, what would it look like on their MRI? It may be new lesions, but it probably would be slowly enlarging lesions. And so some of these newer MRI programs are very good at looking for those things.
Thank you. So this question has a little bit of background, and then I'll ask the question. I've been reading the research of Dr. Alan McDonald, who reports that filial worms have been found in the CSF of MS patients. With that said, what are your thoughts that MS is caused by parasites? And if we can kill them, is there a chance to regain function that may have been lost due to demyelination?
So I have complete respect for anyone doing research, but I would argue 180 degrees the opposite. I think that what they likely found was an association and not a causation. So to my knowledge, that was a fairly small pathology study. I think it was 10 individuals, if I'm not mistaken. Every other bit of research has argued the exact opposite, that parasites are actually associated with a lower risk of autoimmune diseases. And this has come from all over the world for the past probably 30 years. There are studies looking at where we see autoimmune diseases and how that relates to the incidence of parasites. And there is an inverse correlation where you see more parasitic diseases, you see less, not more autoimmune diseases. How our immune system handles parasites, when we look at it, it's almost that when you have a parasite, it has an effect in the immune system that actually puts you at lower risk for autoimmune conditions. There are studies of individuals with MS who've had tapeworms, who've had their tapeworms treated, which you have to do because there are a lot of bad health effects, whose MS got worse after you treated their tapeworm. Researchers at University of Wisconsin, the University of Argentina have done studies looking at treating people with MS with inactivated roundworm eggs, fooling your immune system into thinking that you have a parasite, and have shown a positive effect on MS. So I am not a fan of the theory that MS is caused by parasites and that by killing parasites we're going to make MS better.
Thank you. We have a Facebook question. Karen asks, what are the biggest side effects of the new BTK drug, and how will insurance play into this with Medicare?
So the second question, I mean, That is probably anybody's guess. So I think we want to set appropriate expectations. So when the FDA approves tolbrutinib in September, that does not necessarily mean that it's going to be immediately available to everyone. There is a lag from when the FDA approves a drug to when Medicare and private insurance companies put it on their formulary. There's a lot of steps in there before insurance companies adopt it and start paying for it. We don't know what that timing is going to be. The other question would be, does the drug manufacturer offer some type of drug assistance program while we're waiting for insurance to pick this up? So the second part of the question, I do think Medicare will cover it. The question is when. I think that many of the prime individuals to be on tolbrutinib are going to be on Medicare because it's really targeted towards secondary progressive
Mhm.
MS without activity. That's going to be an older population of individuals. And so I think most people who are going to look at this are probably going to be Medicare recipients. Side effect wise, we need to see what all the final data looks like. I think the biggest concern is going to be liver function issues. Um, it is very likely that this drug is going to be under a safety monitoring requirement from the FDA, meaning that healthcare providers that prescribe it are going to have a certain amount of training and acknowledgement that they're going to follow the safety protocols. And I think the primary one's going to be monitoring liver function studies. There is a suspicion that liver function blood testing may be pretty frequent in the first 6 months. So stay tuned. We'll know the exact specifics, as we get into September.
Thank you. This is a little bit long one. So I'm a 60-year-old female and I was diagnosed 2.5 years ago with MS. I don't take any meds yet because I'm afraid of side effects. I tested positive for the JCV gene and believe that there's a danger of severe nothing possibly going to my brain and possibly causing other complications. Even though it's rare, I'm too scared. So, is there any drug I can safely take, or is it dangerous to continue not taking anything?
So the weight of the evidence would argue that people with MS do better on a disease modifying therapy than not. Now, not all MS is created equally. There are people with MS who follow a fairly mild course over the years and look back over their life at age 90 and say, you know what, I wasn't on a therapy and it was more of a nuisance than anything else. And they're individuals who follow a more aggressive course. But in general, we nudge people towards at least considering starting a disease modifying therapy. So she said something interesting. She said JC virus gene. So typically when we do JC virus testing, we're looking at the JC virus antibody and whether you carry it and then what the levels are. There is new research looking at whether people have a whether humans carry a mutation, a genetic mutation that puts them at risk for PML. And so that test is not FDA approved, but people can access it. What this research has shown is that if you carry one of these four human genetic mutations, that's the prime risk group for PML if you are on a medication that puts you at risk and have other factors. So you wouldn't get PML just by carrying the gene. You'd have to have some of these other things in place too. So that test is not FDA approved yet, but if anyone's interested in doing it, people can go to pmlrisktest.org. It is available free of charge. The company will send you a test kit. It's a cheek swab. You send it back in. There's no cost, and they will tell you whether you carry one of those human mutations. Those human mutations, genetic mutations, are more predictive of the risk of PML than the BRCA gene is for breast cancer, and that's the BRCA gene in breast cancer is pretty predictive. So it's
Yeah.
interesting, and so we do have individuals that like doing that testing. So let's say that has a high JC virus antibody index, or she really carries one of these genes. There are plenty of MS drugs that really don't carry significant PML risk. So, any of your old platform therapies, your interferons, your glutamer drugs, no PML risk there. Really, the drug that we talk about PML the most with is adalimumab or Tassabri. Your B-cell therapies, although there have been rare cases of PML with B-cell therapies like rituximab, Ocrevus, Kesimpta, Briumvi, it's exceedingly rare, and most of those cases were associated with individuals who had been on another drug previously, like natalizumab. There have been some cases of PML with the what we call S1P receptor modulators. This is your Gilenya, Mayzent, Saposia, Ponvory drugs. So again, there are plenty of other options out there that really, for MS, that really don't carry any significant risk of PML.
Thank you. Is it possible to receive my rituximab infusion earlier than my 6 months time frame? I've had some serious crap gap for the past few weeks. Hopefully it's not a relapse.
So yes, so rituximab, when we use that in MS, we're using it off-label. So although we know it works, they never went for FDA approval. Genentech went with ocrelizumab or Ocrevus instead. But we know rituximab works in multiple sclerosis because we're using it off-label. We can sort of use it as we see medically fit. So we do have individuals who take it sooner than 6 months. Some of whether you can do that is going to depend upon what your labs are doing. We want to make sure that we're not pushing too hard with rituximab in a way that would put you at risk for infections. But I mean, I think the soonest we have anyone doing rituximab is an every 3-month infusion. More typically, when we're doing it sooner, it's every 5 months. If someone's experiencing a serious wearing off effect with one of the 6-month IV therapies, the other thought would be going to Kesimpta, which is by design an every month subcutaneous injection. So that's one other way of getting around that crap gap.
Thank you. Tara asks, is MS commonly misdiagnosed as fibromyalgia?
I wouldn't say commonly. They certainly, if you were to read a symptom list, there's certainly some overlap with the symptoms. Things like muscle pain and fatigue, or cognitive dysfunction are things that we see with both. But then when we get into multiple sclerosis, I mean, there are very objective criteria. What we use right now are the McDonald criteria for diagnosing MS, and those have been revised many, many times. The most recent revision in December 2024. So there's always a balance with multiple sclerosis between wanting to get it diagnosed quickly, but also wanting to get it diagnosed accurately. And I think if we follow the McDonald criteria, we're almost certain to get it right.
Thank you. Anonymous question. I have primary progressive MS and am on Ocrevus. What is in the pipeline for new primary progressive MS therapies?
So the BTK inhibitors, those are being looked at for primary progressive MS. And so there's Brutinib, but a bunch of others. There's some interesting, there was data just presented at the American Academy of Neurology looking at an extended release form of glutaramine acetate. So, way back in the day, we did studies in primary progressive MS with Copaxone, and they were technically negative studies, although subgroup analysis would suggest that it did seem to work in men with primary progressive MS. And now data was just presented on a once monthly intramuscular shot of glutaramine acetate in primary progressive MS, and it was a positive trial. I believe that was a phase 2, so there'll be a larger phase 3 study coming up. That there are a ton of other drugs in the pipeline out there, monoclonal antibodies like frexalimab and others. That it's interesting. We've seen a shift from everything focusing on relapsing forms of MS to now a lot of the drugs are really being tested in secondary and primary progressive MS. So there's a lot in the pipeline.
Thank you. Edna asks, have you ever heard of CNMAU8? What is your opinion of this study?
I will confess, I have not heard of that one. So I may have to circle back on that one.
Thank you. And I can email that one to you so you have it. Thank you, Edna. We will get back to you on that. Michika asks, will this new medication, tolobrutinib, help improve disability?
So we wouldn't head into it thinking, we think it's going to slow progression of disability. That said, when you look at any of our highly effective disease-modifying therapies, we do seem to see a subgroup of individuals who do better than slow down or stabilize. It seems like most of our newer therapies, there's always that group that does see improvement. I think if I were starting tolobrutinib, I would want to have realistic expectations. I would head into it expecting it to slow your progression. But in the back of my mind, I would hope I'm in that group that maybe gets better than that. But I think that the downside to heading into a new treatment, expecting it to make you better, is that if it doesn't do that, you consider it a failure when maybe stopping your progression is really it's a success. And then what I think is with a lot of our therapies, if we can stop progression and let science catch up to give us a repair strategy, that for many people is a success.
Yeah, thank you. Sherry asks, what are your thoughts on probiotics and what kind?
So we know that the gut microbiome in people with MS, primarily people who are not on treatment, looks different than the general population. So our gut is our first line of immune defense. It's how our immune system kind of recognizes a lot of things in our environment. So clearly there's something there about the gut microbiome. There was just a study that identified a specific bacteria that seems to be unique to the gut microbiome in people with untreated MS. So would restoring the normal gut microbiome with a probiotic make sense? Yes. I think which one you pick, there's so many out there, and I think the higher number of bacteria, probiotic bacteria that you can get, probably the better. There's also going to be issues with individual tolerance. Some people start probiotics and their gut just goes wonky. They get gas, they have abdominal cramping. So there can be some trial and error to figure out what's going to work out best for you as an individual.
Thank you. Karen asked a two-part question. Is it possible that the fatigue symptoms in MS are actually caused by activation of EBV? And
That,
do you want the second half or?
yeah, let's do the second half too.
Okay. Do the anti-EBV MS meds in development seem to help with this fatigue?
So second part first. That is not a specific primary treatment outcome in the research project. They're tending to look more at the usual things: relapse rate, MRI lesions, progression of disability, but they will capture things like fatigue as maybe a tertiary outcome, but that's not what they're targeting primarily. I think the first part is an excellent question, and we don't know the answer to it. We are learning more and more about EBV all of the time. We've always known that there is an association between Epstein-Barr virus and MS risk. The Stanford researchers 2-3 years ago identified the receptor on myelin basic protein, the antibody that's being produced, that's being driven by the Epstein-Barr virus. We hope that leads to treatments. So we also know that Epstein-Barr virus lives in our central nervous system forever. So I think it is possible. I mean, if you look at young people that get mono, fatigue is a big part of mono. So I don't think it's entirely impossible that something about fatigue and MS could be tied in with how our immune system is dealing with Epstein-Barr virus.
Thank you. Sarah asks, I have MS and Crohn's. Currently, I'm on Tassabri, but will be coming off as my Crohn's is active and my JCV titer is rising. Have you dealt with both diseases, and what other cocktail of medications have you seen work, if any? Having both diseases seems to be a challenge. My MS doctor is leaning towards Mavenclad next.
So I think the appeal, obviously, to natalizumab or Tassabri is FDA approved for both conditions. I apologize for the background noise in the parking lot. Somebody's being very noisy. So I think in terms of what else you would use, that's a tougher question. There is no other FDA-approved therapy that covers both Crohn's and multiple sclerosis. I have seen people, I think the appeal to Mavenclad is, again, it's very effective in MS. I'm not aware of any literature in Crohn's disease, but you would think it could possibly, because of the way it resets the immune system, it could possibly work there. What I've seen in some of our folks with both Crohn's and MS, if we can't use natalizumab, is they might end up on something for MS, something for Crohn's. There are obviously things in Crohn's that we absolutely don't want to use in MS, and that would be any of the TNF alpha agents. So things like Humira, those have definitely been shown to be associated with a risk of MS relapses. So um, I was, one other one that I've seen sometimes cover both conditions, and this one's tricky, would be the B cell therapy rituximab. I do have a lady with MS who's with Crohn's and MS who's on rituximab, and it covers both diseases. The trick there is one of the side effects of our B cell therapies on occasional is a colitis. So so if you go on a B cell therapy and you start having new GI symptoms, is it because the B cell therapy isn't covering your Crohn's, or is it because the B cell therapy is causing a different GI issue, and that can get tricky.
Thank you. Anonymous attendee, I want to stop Tassabri. I've been on it for 3 years with no relapses, and I really want to go on a pill form as a DMT. What would you recommend?
So we've talked a fair amount about Mavenclad. Some people think of Mavenclad as a nice kind of transition when you're coming on, and there is a fair amount of data out there looking at people going off of Tassabri going to Mavenclad. I don't think any of the oral therapies would be on the table for discussion. Um, so I would say Mavenclad is probably our most effective oral therapy, and then you go to the S1P receptor modulators. These are again are your fingolimod, Zeposia, Mayzent, Pomfori drugs. Probably the least effective but very safe option would be Aagio or teriflunomide. Some people think that depending upon the person's age, maybe Aagio is perfectly acceptable. If you've had great MS control for a while and the person's getting older, maybe their immune system is not as aggressively inflammatory. Maybe they don't need a big gun therapy, so maybe teriflunomide would be perfectly acceptable. So I think any of the oral options. We didn't talk about the fumarate, so this is your dimethylfumarate, Tecfidera, the Vumerity type drugs. I mean, those are certainly on the table for discussion as well. Personally, if this person I would say is under age 60, I probably would lean towards Mavenclad just as a nice exit strategy.
Thank you. Kevin asked, does MS increase a risk for shingles?
MS by itself does not. So if you have untreated multiple sclerosis, you have no higher risk of shingles. Some of our disease modifying therapies might add some increased risk for shingles. Although MS doesn't put you at increased risk for shingles, if you do get shingles, because it's a viral outbreak, there's a chance that you could have a pseudo exacerbation and your symptoms are going to flare up just because of your immune system being activated to deal with that herpes infection.
Thank you. Lisa asks, I was diagnosed with relapse remitting MS in January and told I have it mild and no disabilities as it was caught within a year. I started Kesimpta in March with no side effects. What's the probability that I will remain disability free with the above factors?
So I mean, she's got all the great things going for her. She was diagnosed quickly. She's on a highly effective therapy. Um, I mean, we see individuals down. So when we look at the Kesimpta studies, I cannot remember the numbers right offhand of the people that were free of progression of disability. It was significant, and I believe in the 50% or greater range. In my experience, I see most of our young individuals who are put on a highly effective therapy like a Kesimpta stable many years out. I have the highest of expectations in situations like this that people are going to remain disability free. My hope is that they for life is that so we have great therapies like Kesimpta and other B cell therapies and other options right now, and we know that this is not the end of the story, that we're going to have more and more developments as time goes on. So I really do have high expectations for young individuals who are caught early and are started on a highly effective therapy quickly.
Thank you. I apologize. I'm going to butcher your name. Christian asks, what's your opinion about amantadine sulfate? My neurologist prescribed me 50 to 100 milligrams daily for fatigue.
So the studies on amantadine, and it's an old anti-influenza drug. It was just a fluke that we discovered that it works for fatigue and MS. The response rate is about 40%. So you'll know within a month if you're in the responder group or non-responder group. So again, 40% of people do get a nice energy bump with it. About 60% don't get so much, and we move on to something else then.
Thank you. Anonymous question, can muscle relaxers be taken as needed for spasticity? And if so, what are the common dosages?
So when we think about spasms and spasticity, the two that we use most commonly would be baclofen or tizanidine. Baclofen, we start either 5 or 10 milligrams per dose. It can be taken up to 3 times a day. Tizanidine, 2 to 4 milligrams 3 times daily. They can be used as needed. The one precaution is if you are taking baclofen 3 times a day regularly, and to me, regularly means probably more than 5 days in a row. So you've got a steady blood concentration. We want to be a little cautious about stopping that abruptly. There is some seizure risk. It's low if you're on a low dose. We worry more if someone's on a very high dose, like say 80 milligrams a day, and they stop that abruptly. So that is just the one precaution about using baclofen as needed. Some of the things that we don't typically think of for MS spasms and spasticity, like Flexeril or cyclobenzaprine. And some people with MS do get some relief with that and used on an as needed basis. And that's typically going to be a 5 or 10 milligrams up to 3 times daily. And that was designed to be on an as needed basis.
Thank you. Marietta asks, have the safety studies been conducted for the Tassabri biosimilar? My neuro says it's stronger than Tassabri and therefore more risky for PML.
So they did a head-to-head trial of the biosimilar versus the name brand. And from a statistical standpoint, it did look like it was a little bit more effective. The safety signal was exactly the same. I'm not sure how much I'm buying into the more effective yet. I mean, I don't know that it's truly going to be more effective. I think that we want to use the same cautions with the biosimilar that we do with the name brand. We want to be thoughtful in who we select to be on that drug. We want to do the same safety monitoring, checking JC virus antibody index periodically. So I'm not heading into the biosimilar version of Tassabri thinking that it is more or less effective and more or less safe. I think we want to use the same precautions and thoughtfulness with this that we do with the name brand.
Thank you. I'm going to combine two different questions because it's similar. So, how do you feel about long-term Ocrevus use? I've read that possibility once B cells are depleted to a certain range, you could stop the medication. And does it cause thrush?
So because of its immune suppressant properties, it could be associated with a slightly higher risk of thrush. I've not seen that commonly. I wouldn't say it's a common side effect, but again, it is a mild immune suppressant. There's a lot of interesting research looking at dosing of Ocrevus. Initially, there was some thought that maybe there were some people who would benefit from a higher dose of Ocrevus over time based upon some subgroup analysis from the original studies. That seems to have been laid to rest. There was data that came out earlier this year that said in a study they did with either 1,200 or 1,800 milligrams of Ocrevus versus the usual 600, the higher doses didn't seem to add any more benefit in relapsing forms of MS. I think there's still some studies in progressive MS. It looks like what the B cell therapies like Ocrevus might be doing is sort of resetting your immune system. And sort of when the B cells come back, they might be less inflammatory in a way that's going to give long-term benefit. There have been studies looking at 9-month dosing versus 6-month dosing. It seems to be just as effective. There have been studies looking at lower doses of B cell therapies. There was a rettoximab study in Europe that looked at a half a dose of rettoximab. It seemed to be as effective. And one of the benefits of these sort of lower dosing or longer dosing intervals is they seem to be associated with less side effects. There was a study that looked at discontinuing Ocrevus, so it was Ocrevus, Tassabri, or Gilenya being discontinued in older individuals. The group that did the best was the group that went off of Ocrevus. They seem to have a long-term protective effect. So, I'm pretty willing to play with dosing on B cell therapies in individuals that are stable. Look at spreading it out to 9 months or even lowering it. And as we get older, the ultimate goal is maybe at some point can the person come off altogether.
Mhm. Thank you. Anonymous question, is it possible for lesions from MS to decrease in size?
So they can. It's usually a very unique situation. So when an MS lesion is new, 4 to 6 weeks old or younger, a lot of the volume of that MS lesion is edema. It's water from inflammation. And that water or edema goes away with time. So MS lesions will, if you happen to catch them brand new, they're naturally going to likely shrink. Sometimes they shrink below the resolution of the MRI. That seems to be about 5% of new lesions will actually disappear completely. So that is a very unique situation. We typically don't think of MS lesions going away. So that's not to say that you could be repairing damage within an MS lesion or restoring function. Most of what the white spot within a MS lesion represents is gliosis. If you were to remyelinate an MS lesion, there's a good chance it's still going to show up as a white spot on your MRI, even though you've maybe restored function within that. I think the other situation where we see lesions disappearing may be in the person with MOGAD, myelin oligodendrocyte antibody disorder, who has been mistaken for a person with MS. Those lesions commonly disappear. You'll see very angry inflammatory lesions, and then you repeat an MRI, and they're either much smaller or they're gone altogether. And there is blood testing for that condition. Typically, in newly suspected individuals with MS, they're going to get a lot of blood tests done, looking at other autoimmune conditions, looking at this myelin oligodendrocyte antibody or MOG antibodies, probably testing for a cousin of MS called neuromyelitis optica spectrum disorder, just to make sure that we're dealing with the right demyelinating condition.
Thank you. I'm just going to ask a couple more questions because I know we're nearing the hour. David asks, I'm 61 with relapsing remitting MS. I was on Copaxone for 9 years, now on dimethyl fumarate. Is there a stopping point for the treatment?
Yeah, again, that's one of the hot topics, the whole idea of de-escalation from therapy. So I would certainly talk to your healthcare team. Yes, that is, open for discussion. The age at which we have that discussion is the Disco MS, discontinuation MS trial went as young as 55. Some people start having the discussion at 60, 65. This is definitely a situation for shared medical decision making. Your individual risk tolerance, based on what the science says, is going to drive that decision to a large degree. And I would argue there is no absolute right or wrong answer. We have 80-year-olds who are still on disease modifying therapies because it's what they feel most comfortable with. And in my opinion, there's nothing wrong with that. If that's as long as we're all on the same page, we've talked about risks and benefits, and that they have all the information to make an informed decision.
Thank you. Marietta asks, if I have a retinal nevus, is Mavenclad too risky for me? I'm tired of fighting insurance to get my Tassabri that has kept me relapse free for 9 years.
So, Mavenclad does carry a warning for cancer risk. Um, that is somewhat unique to the United States. In some of the European countries, it does not carry that warning. We've not seen any cancer signal, in post FDA approval marketing. So most of us believe there really is not a significant cancer risk with Mavenclad. That said, that warning is probably never going to go away in the product information. That would take a very large new study that probably is not going to be done. So what we typically do in these situations is you talk to you have a coordinated talk between the ophthalmologist or whoever's monitoring that nevus and say, listen, we think that Mavenclad is the best option for this person. Put a letter together from the ophthalmologist and the MS neurologist, and then have an argument with with the healthcare company. Yeah, the bottom line is there really is no inexpensive disease modifying therapy, with a couple of exceptions. So if that's what your MS team feels is the best option for you, I think most of us would argue that you could do it safely, in spite of that nevus.
Thank you. I'll ask one last question and we'll wrap it up. How do you know if it's relapsing remitting or primary progressive MS? I was diagnosed 5 years ago and have continued disability progression. I'm on Ocrevus, have a baclofen pump, and take Empira. Yet I cannot walk without a walker and continue to struggle in PT 3 times a week.
So that distinction between relapsing MS and primary progressive really is going to be based upon the history. So if you go back in the history, if there truly was never an acute relapse, I woke up one day and I had new weakness, new visual loss, new sensory symptoms. If it was always slowly progressive from day one, you could make a better argument that is primary progressive. Typically with relapsing MS, by definition, there should have been something that would count as a relapse early on. Once someone has an established diagnosis and is on treatment, that's where the distinction gets a little fuzzier. When we say relapsing remitting MS, remission would seem to imply that I'm symptom free, when we know that's not true. People with relapsing remitting MS who are well controlled still have to deal with symptoms, and walking issues could be one of those. Could the walking issues that that person is dealing with be left over from prior relapses or prior underlying inflammation in the brain? What we're learning with even in relapsing forms of MS is that whereas in the past we thought relapses were what drove most of the disability, and they can drive some of it, now we know that underlying continuous inflammation is probably what actually drives most of the disability in relapsing MS and progressive forms of MS. You could argue that the question may be somewhat academic in that Ocrevus is FDA approved for both options and is probably one of the more effective therapies. So, I'm not sure that making the distinction would necessarily lead to a treatment change. My feeling in individuals like that are on a highly effective therapy who are struggling with walking issues and disability is the best thing we can do for them is very aggressive rehabilitation. I think we probably miss out sometimes on aggressive rehabilitation because I think in terms of improving function, that's where we're much more likely to do it than through a medication.
Thank you. And that brings us to the end of the hour. If you missed any part of the conference, it has been recorded and it's available on our Facebook page via live stream, and it will be on our YouTube channel as well. Please reply to the registration email if you have any questions about how to get access to the recording or to sign up for our newsletter. Our next teleconference is next Tuesday at 7 p.m. Eastern with Tiffany Malone, who will be talking about mental health, specifically strategies for managing MS stressors successfully. There's a survey that comes at the end of this conference. Please fill it out. It takes 30 seconds, maybe 2 minutes. And it just allows us to get more insight on what topics you as the attendees like to register for and come attend and ask your questions towards. With all of that said, I really want to say thank you, Dr. Thrower. Usually I'm on the back end of this, but seeing it on the front end and seeing how many questions you answer in an hour is truly remarkable. So thank you for all the time you dedicated.
Thank you.
Thank you as well. And thank you to our attendees for all your participation via Facebook, via phone, and through your computers. I hope all of you have a lovely rest of the day. And thank you so much, Dr. Thrower.
Thank you. Take care, everybody.